It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. We have a lot going on here. We have ultrasound courses on a nearly monthly basis in New York and elsewhere. The next one is going to be in June in Manhattan, and that's combined with the board review course with Al Abdul El Sayed, as well as in July and August we have ultrasound courses in New York, going to Puerto Rico in September. Hope to see you there, and hopefully much more to come. If you are looking to prepare for your anesthesia, pain, PM&R boards, or you're a nurse looking for educational experience online for pain, come to nrappain.org or painexam.com, and you'll have access to our board reviews, CME credits, and much, much more. So today I'm going to discuss the sacroiliac joint because there's been a lot of talk lately as to CMS's their stricter rules with respect to billing for this joint. And if it wasn't pain in the butt, as it was, no pun intended, it's just getting more and more restrictive. So I'm looking at CMS's website, and there's a few, my billing company sent me some summary of this, as well as I searched and I found something on Doximetry. Basically, let me just summarize, and I'm going to paraphrase a bit and also just copy directly from them. But they say that low back pain is prevalent in the Medicare population, no kidding, with about 50 to 84% of adults experiencing back pain at some point in their life, and 15 to 30% have persistent mechanical low back pain below L5, and this pain arises from their SI joint. SI joint dysfunction is common after spinal fusion, reported in up to 40% in some studies. And the joint is a diarthroidal joint with matching articular surfaces between the sacrum and the ilium. It's separated by synovial fluid and surrounded by a fibrous capsule. It is only a true synovial joint in the anterior portion due to discontinuity of the posterior capsule. It serves as a biomechanical mediator between the spine and the pelvis. The joint is responsible for flexion and extension of the sacrum with counter-rotation of the ilium, and there's only a small amount of movement. In early childhood, the surface of the joint is smooth, allowing gliding motions in many directions. After puberty, the surface of the ilium becomes rougher and coated with fibrous plaques that will restrict motion significantly. The age-related changes will increase in the third and fourth decade, and by the sixth decade, motion may become noticeably restricted. By the eighth decade, plaque will form and erosions will be present. The SI joint has variable joint capacity as the SI joint degenerates with age and is varied from 0.5 to 2.5 mLs. The exact pattern of innervation is unclear, but the subchondral bone capsule and surrounding ligaments are innervated by spinal nerves with nociceptor and proprioceptors, and therefore can be the source of pain from the SI joint complex that may arise from the posterior extra-articular elements that are innervated by the lateral branches of S1 to S3 and the L5 dorsal ramus, or the anterior complex innervated by spinal nerve branches of the gluteal and obturator nerves and lumbosacral trunks known as the intra-articular elements. The spectrum of pain and dysfunction, they write, from the SI joint pain can be variable and debilitating. There are surgical modalities to treat SI joint pain, such as RFA of the SI joint. Injections typically are intra-articular and contain anesthetic and steroids. Ablation relies on our radiofrequency thermal energy to ablate the sensory nerves of the SI joint, interrupting nociceptive signals. Treatments of individuals with spinal disorders, including pain, can be complex. We know that. And I'll move on to the next subject. So, covered indications. The SI joint considered medically reasonable and necessary. The injections will be considered necessary and reasonable, medically necessary, if you have to have all the following. Moderate to severe low back pain, primarily experienced over the anatomical location of the SI joint between the upper levels of the iliac crest and the gluteal fold. And low back pain of at least 3 months. And low back pain below L5 without radiculopathy. And clinical findings and or imaging studies do not suggest any other diagnosed or obvious cause of lumbosacral pain, such as central stenosis with neurogenic claudication myelopathy, foraminal stenosis, or disc herniation with concordant radicular pain, radiculopathy, infection, tumor, fracture, pseudoarthrosis, or pain related to spinal instrumentation, and at least 5 positive findings with at least 3 positive findings, 5 would be crazy, with provocative maneuvers, the FABER, the Gaenslens, the thigh thrust or posterior shear, SI compression, SI distraction, and Yeoman Test. And low back pain persists despite a minimum of 4 weeks of conservative therapies. So overall, this sounds okay to me, just a little editorial. I'm not happy about radiculopathy cannot be present. Yes, obviously you don't want to give an SI joint injection in a patient who has pain related to radiculopathy, but what about the patient who has coexisting disorders, which I see plenty of, right? You do the epidural, they respond, but there's still this tush pain that in their exam goes along with SI joint pain. They still might not fully respond to that epidural. They still may have some radicular pain down the leg, but they still have arthritis of the joint, and they can go hand in hand, right? So it's kind of pushing those patients to the side, it sounds like. So now they talk about diagnostic SI joint injections, which is used to determine if the pain the patient is suffering is from the SI joint. And they're considered reasonable and necessary for all patients who meet all the following criteria. Patient must meet the above criteria covered for SI joint. So we already established that. The injections must be performed under CAT scan or fluoroscopy. I don't know anyone who does CAT scan for this. With contrast, accept ultrasound guidance and may be considered reasonable and necessary when there is a documented contrast allergy or pregnancy, since the accuracy with ultrasound guidance is inferior to fluoroscopic guidance, and there's a reference to show that. SI joint injections are not performed with other musculoskeletal injections in the lumbosacral spine, and documentation shows direct causal benefit from the SI joint injection and not from other musculoskeletal injections and treatments. The SI joint provided a minimum of 75% relief of primary index pain with diagnostic SI joint. A positive diagnostic test is over 75% sustained relief and constant pain relief for the duration of the local anesthetic, and over 75% sustained and constant relief for the duration of the anti-inflammatory steroid was measured by the same SAME, like capital SAME, pain scale at baseline. The measurements of pain must be taken pre-injection on the day of the SI joint injection and post-intervention on the day of the injection, and the days following the injection to substantiate and corroborate the pain scored consistent with the pain relief for the duration of the local anesthetic and or steroid used. Limitations: no more than 2 diagnostic joint sessions, unilateral or bilaterally. To clarify, 2 unilateral sessions if performed on one side at one session, and on the opposite side at a different session would meet the limitations of 2 diagnostic sessions. Okay, so do both sides together, it sounds like. That's how I interpret this. Therapeutic SI joint injections will be considered medically reasonable and necessary for patients who meet all the following criteria. The patient must meet the criteria for the covered indications for SI joint injections that we mentioned above, obviously. And the SI joint provided a minimum of 75% relief of primary index pain with diagnostic injection. And that was, I'm going to skip a little bit here. Subsequent SI joint are considered medically reasonable and necessary with subsequent SI joint at the same site if they provided therapy at least 50% relief or at least 50% consistent improvements in ability to perform previously painful movements and activities of daily living for at least 3 months from the proximate therapeutic SI joint injection compared to baseline levels. SI joint must be performed under CAT scan or fluoroscopy unless there's a pregnancy or contrast allergy, just like with the epidurals. Limitation: no more than 4 therapeutic SI joint sessions, unilateral or bilateral, will be reimbursed per 12 rolling period. To clarify, SI joint session is performed on one side and then performed on the opposite side. That would be 2 sessions, so 2 of your 4 sessions are used up. SI joint denervation or RFA is not considered reasonable and necessary, and that's really a shame because it actually works quite well. At least I've had very good experience with that. And then you're doing all these diagnostic injections for SI joint, so you're just really now doing diagnostic injections to see if you could do a therapeutic injection or send them to surgery. Well, I kind of disagree with that. That I think we should be doing RFAs, or at least they should cover PRP or something that can give longer-term relief and may be safer than steroids. Anyway, there's a lot more to this LCD page. I'll have the link in the show notes. It's CMS's website. Just check it out. None of us want to get caught with our pants down when it comes to this stuff. Everything's getting more restrictive, unfortunately, and I understand the government's trying to save money. So I get that. And we do need to be scientific about our approaches to our procedures. However, the problem with SI joint pain is sometimes it's purely, from my experience and my knowledge, which I don't know everything, of course, but from my knowledge, it's sometimes typically SI joint arthritis. The joint's inflamed or there's degeneration, like I just mentioned. And then sometimes there's ligaments or fascial coverings over the joint that can present exactly the same way. And maybe you don't even need to get a perfect diagnostic arthrogram that they see in the textbooks to get therapeutic effect. I remember in fellowship, they taught me inject in the joint and around the joint to get the maximum chance of helping the patient. And it makes sense because it's not just a joint that hurts sometimes. So you don't, some people you can't get a good contrast spread because their joints are fused or they're just so severely degenerated. So anyway, SI joints are definitely something that most of you are doing, and there's utility to it. As far as the ultrasound goes, I really have mixed feelings about that because it's a quick, easy, safe way to do it without radiation. But at the same time, it may not be as accurate, and you don't want everyone just picking up an ultrasound, watching a video on YouTube, and just doing it because then that could lead to possibly more misuse or complications or whatnot. Anyway, if you are interested in learning ultrasound, come to one of my courses. YouTube is nice, but you can learn a lot more in person. Anyway, I hope this was useful. Have a great rest of your day, and stop by my new website, nrappain.org, where we offer more board review training. I redid pain exam on that website, so it may be a little bit of a different experience for you, but it's the same content. So you could do either one, therealpainexam.com or nrappain.org, where we have anesthesia, board prep, PM&R board prep, and I'm going to be adding more services to this website very soon. Thanks again. Take care. Good luck.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.